Good employers know that health benefits can make or break your business. But while employers are looking out for their employees' best interest, who is looking out for theirs? Sona Benefits is an independent pharmacy benefit manager who partners with employers to optimize their pharmacy benefits while supporting their business goals. But by offering no-spread pricing, contract guaranteed rebates, and the Sona Max program, clients are regularly able to save 20% to 35% off their total drug spend. The result? Pharmacy benefits that improve employees' well-being and employers' bottom line.
What if 1 year could transform the way that you lead? At Tallahassee University, our Leadership Excellence program equips leaders with the purpose, the skills, and the confidence to create lasting impact in their organizations and their communities. This is a 100% virtual program that offers expert faculty, mentoring, and a collaborative learning experience that many graduates describe as life-changing. Join our upcoming interest webinar on August 11th to learn how you can become part of the next cohort. Register today using the link below. Tallahassee University. Step into your potential and lead with purpose.
Welcome to TCNtalks, an anatomy of leadership. We continue the conversation with Kelly McCutcheon Adams and Margherita Labson in part 2, Embracing the 4 M's, a path to person-centered, reliable hospice and palliative care. And now, here's our host, Chris Comeaux.
Well, as we go to this next segment, we talked about what matters most, great place to start, and then we actually went to med. So let's now go to mentation. So Kelly, you probably want to start with this one. So, mentation focuses on cognition, depression, delirium, emotional well-being.
Mm-hmm.
Is this area often overlooked, or why is it overlooked in serious illness care? And how can we do better in the hospice and palliative care space?
That's a great way to phrase the question, because what I think happens, and Margherita, I'll value your opinion here. What I think happens is that we mistake what can be solved at the big level, at the big level, with what can be aided at the small level. And so what I mean by that is, if someone is on hospice and has dementia, and there aren't cures currently, but we can't move that big needle. That's not going to happen in any way. But what can we do that will help that person feel more grounded, more at peace, more comforted, more cared for? If we're talking about depression, are we going to fundamentally be able to see a very significant change before the end of that person's life? Probably not. But should we overlook things that might bring them peace and comfort and groundedness? With delirium, and this is the one this one's, to me, Marguerite, is big, because if we are overlooking a reversible cause of delirium, we are missing such an important opportunity to perhaps, if what matters to someone is being able to engage with their family, and they have delirium, and maybe it's hypoactive delirium, and we're not even recognizing it, and they're just blotto, they're not, if we miss that chance, we might be stealing time away from that person to engage with their family. So it's not that we can rush in on our white horses and fix, every aspect, dementia, depression, delirium. These are big, big things. But if there are aspects of reversibility or treatment that could bring someone some comfort in the final stage of their life, why would we ever turn away from that? So that, to me, I don't want us to overlook what is possible. But Margherita, you might have a different perspective there.
Well, I think what you just highlighted is the benefit of the expertise that we have in medical science to assess what's the probability that we have something that is let's take the delirium. The delirium is a reversible situation. So immediately what I think of is that particular individual who's having a symptom that the team cannot manage in the home, and we require a GIP stay. Okay, general inpatient, for those of you that are not familiar with hospice, general inpatient stay. Okay, well, we know that if we've already got somebody that's on narcotic opioids and they are an older adult, that there is a likelihood that we could be facing a situation where that individual is going to experience some delirium. Well, it's not just a matter of, okay, we're going to medicate to the delirium. Now it's a situation of, let's anticipate that, and how can we, help if we think that this is a potentially reversible delirium because we're changing site of care and this team that's going to be caring for that individual is new. What can we do as a team? And they will enact and come around that individual. So maybe we have members of the IDT that typically see him in the home are also seeing him now in the GIP, and we are communicating information to the IDT in the GIP unit that is picking that individual up and providing care, saying, no, you are going back home. This is just temporary. It takes a lot of work. It takes a lot of work, and it takes a really thoughtful level of intentional communication of what matters to that individual. And by the same token, there are times where we know that a state of altered mentation is likely to be permanent. So how do we then support what matters to that individual and keep the experience as pleasant as possible?
So well said. Something occurring to me. I'm reflecting on the podcast with Dr. Berwick, and in that whole podcast, the brilliance of what was the triple aim and the quintuple aim, and what that, like, I'm sitting here having the same reflection of the brilliance of like striping the 4Ms across all the segments of healthcare. It's like there's these depths of knowledge and expertise that you could apply at different places and different times. You're opening my eyes, which is exactly why I wanted to do this podcast, that there are new lands to be discovered here, which maybe this is a good segue, because this might be the one that people are like, okay, I get what matters most. I get the mentation or medication, then the mentation. But what about the mobility? So I think a lot of people don't immediately associate mobility with hospice and palliative care. Why is this still important for people that are living with their serious or advanced illness?
Well, I can start, Kelly, and then.
Yeah.
So mobility is a part of life. Imagine, if you will, you can't scratch your nose. That's mobility. All too often, again, because we have this influx of, we've got a patient coming in, we've got this going on, we have staffing changes, we have staffing challenges, we have resource challenges. All too often we override it, and we override to the default, and the default becomes fall risk assessment. Why? Because we're measured on fall risk assessment. This is mobility. So again, looking at that North Star, what matters to that older individual? We don't ever want to distill mobility down to simply a matter of a fall risk assessment. Instead, you look at what is the ability of that individual to independently enjoy eating an ice cream cone while he watches the Yankees play, or perhaps it is the ability of somebody to wash their peri area because their spiritual beliefs dictate that modesty prevail. I think the simple importance of safely transferring to a commode. Is safety and fall risk built in there? Of course it is. Of course it is, because what would be mobility if it didn't have a component of safety? But the idea is it's more than just a fall risk. Always go back to this little lady who couldn't, or who just wanted to be able to always turn on her left side when she wanted to, because if she laid on her back or she laid on her right side, the right side of her body would go numb. And all she wanted to do is be able to turn to the left side. That's mobility. Did we worry about, making sure that she had side rails up and that she couldn't fall out of bed? Of course we did. Of course we did. But our primary driver on that team was to make sure that for as long as possible, she could independently roll on her left side when she needed to. It's different piece, much broader, much more relevant based on what matters to that individual.
Yeah, Margaret, you reminded me. So I got to work with Dr. Janet Bull at Four Seasons, where I spent a lot of my career, Nashville, North Carolina area. And we had a research department. And I remember the first time she said this, I'm like, what? But they were actually doing a research study of trying to incorporate physical therapy much more in the front part of the hospice admission, which at face value is antithetical. But over the course of time, I started to see the brilliance of what she was poking on. Interestingly, one of our TCN members recently, patient wanted to stand. He had been bedridden. He wanted to stand and hug his daughter before he passed. And we actually accomplished that. And it's such a beautiful story. And that's what mattered most to him. Did it challenge the team? Would it have been easier for us to go, well, that's not what we do. But yet that's what mattered. And it was just such a beautiful story. And he actually did that. I think he passed away a couple of days afterwards. But that's what mattered most to him. Well, I've got an interesting question for you guys. As I was preparing, I kind of ran into a curveball, may not be a curveball to you, but in some recent years, some geriatric leaders have started to maybe discuss, is there a fifth M, which is multi-complexity, which recognizes the realities of multiple chronic diseases, social determinants, caregiver burden, fragmented systems. How do you guys view this?
Yeah.
It's so fascinating, right, to see how the triple aim has now grown to the quintuple aim. And then I've heard some people are calling like the sextuple aim that is safety. And at some point you kind of go, okay, are we getting too far afield? Or are these really so I'd love to hear your wisdom.
Yeah, that you're by bringing up the, quintuple aim and the evolution there, you're raising the fundamental question, which is, where does the utility of a sticky framework take primacy over the opportunity to perhaps deepen it? And so I think that's a really important question. And I'm gonna quote my friend Amy, who says, we have the word simplify. Why don't we have the word complexify? So I'm going to indulge in bad grammar and use the word complexify. There is a risk here, and we have certainly talked about and considered the addition of M's, multimorbidity, malnutrition. Those are examples that come up a lot. The risk in complexifying, again, I promise I know that's not a real word, is that you lose the stickiness of the framework. You lose the ability for people to hold that and navigate it in a reliable way. And so what we have found, and the conversations that happen a lot, this is an important conversation, I don't want to be dismissive of it at all, is that let's use multimorbidity as an example, that actually, the components of that actually are woven through the current 4Ms, that is not absent from that. And so I think we have to find that tipping point of when does it become too much to remember or to navigate. But what we also recommend is that we have supported organizations who have made that decision, that they've decided, you know what, we're gonna add a fifth M. And what we encourage people to do is to really have clarity about why. What is missing that makes that complexification worthwhile? And so I think as long as people are being really sound in that, but there are no current plans to go from a 4M to 5M.
I love that answer, Kelly. You will love this fact that we use the word uncomplexify all the time in our lexicon at TCN. And so I love your answer on that. So this one I think I'd love for both of you. So looking ahead to say 5 years, 3 to 5 years, what would success look like if the 4Ms became deeply embedded throughout hospice and palliative care? How would patients, families, clinicians, and communities experience care differently?
No more elated myths. I'm going to just speak from a clinician's heart. No more elated myths. No more individuals electing the benefits, based on when their family decides that they need hospice rather than when they need hospice. Thinking about this very intentionally, delivering hospice care that really is of value to that older individual and fulfills the hospice philosophy, the hospice mission, to support that individual that has invited you in during the last and most important part of their lives to optimize the quality of their life. That's what it means. From an administrative standpoint, my work as an administrator, and it means leveling out the number of cost overruns I have. It means effective healthcare work. It means reliable healthcare practices that are not overly complicated. It means meeting regulatory demands without continually throwing out, oh, and do this, oh, and do that, oh, and do this, oh, and do that. It focuses the work on that which produces a reliable result. Think of what that means across the care continuum based on what we have currently, a fragmented healthcare system where everybody's trying to do their best and get the job done to meet a patient's needs.
I love that answer, Marguerite. One of the things that when I was a hospice social worker, which was not a long part of my career, it was my internship and then shortly after my internship as a social worker. One of the things that broke my heart the most was a 12-hour admission, a 24-hour admission, because that to me represented such a failure of the whole system, that the whole system had failed. And I know that's a hard word, but that's how I view it. That within our fundamentally death-denying culture, that the system had failed. And when as my career advanced, went on, and I became a trauma ICU social worker, an emergency department social worker, and I just remember just some nasty, fights with physicians about where we were, in someone's life, and being screamed at, "I'm not giving up on this person." And I was like, oh my gosh, how broken are we if we can't stare at the very obvious thing that's happening in front of us and do right by that person? And again, I'm speaking very pejoratively, and I will circle back, but that all leads to the 12-hour admission, the 24-hour admission. That all leads to not being able to get to know people and focus on what matters to them. And so I think 5 years in the future, 10 years in the future, I think if we do this well, we will see fewer and fewer 12 and 24-hour and 48-hour and 72-hour admissions, because there will be continuity of conversation and care about what matters. And in the hospital, in the ambulatory care setting, clinicians will be better able to say, you've shared with me what matters to you. And I think the best way for that to be achieved is for you to receive hospice care so that you can be at home, so that your family can be with you, whatever aligns to that. So I think if we could build that continuity where what matters is what's driving the bus, I think we would have better and more powerful ways to talk about hospice care as being in service of what matters. And we could get away from giving up, the notion of giving up. We're not giving up. We are looking at what's in front of us and trying to do the absolute best by that person, which could mean going home and not sitting in the hospital with a bunch of tubes. And I'm just going to briefly say at a personal level, I am the person, I'm in my mid 50s, my friends, my own parents, my friends' parents, we're in that moment. And when my friends call me and they say, my 88-year-old mother's about to have an endoscopy for, blah, blah, blah. And I say, what matters to your mom? What matters? Is that process and test going to move her towards a true connection to what matters? So I think the whole system, when aligned and with good continuity, could move us towards much more effective and powerful use of hospice services. I hope it's not a fairy tale, but that's where I think this could go.
That is brilliantly stated, Kelly. We actually, we had a work group. We called them future councils last year that wrestled with different challenges that we're all facing as hospice and palliative care programs. And that was one of the conclusions that we came to, is that the 4 M's are a framework that kind of busts the linguistic challenge of talking about what we do.
Yes.
The joke is always, everybody wants to go to heaven. Nobody wants to die. Like, how do you talk about this care that we provide, right?
Yes.
Because they all think hospice equals death. I high five you. I think you just stated that brilliantly. Well, let me ask you both, maybe Margherita, you go first on this final question. Weave your final thoughts into this. So if you were advising a hospice leader, CEO, or just any hospice leader, and I'm almost kind of leading the witness, our listeners here, who hopefully want to compete based upon quality, rather than just simply survive the regulatory and reimbursement pressures, where would you tell them to start with the 4Ms? And of course, again, weave any other final thoughts. It's almost like, your halftime talk to them.
Right. So I would tell you, if you're looking for quality, nothing speaks louder than the story of an older adult's journey through age friendly. Okay. And as a corollary to that, talk to the clinicians and hear their journey if you want to really enhance your employee satisfaction. And having said that, the one thing you need to do as leaders is really understand what matters to healthcare consumers. And if you understand what matters to healthcare consumers, then you're well on your way to understanding what age-friendly care is all about. Get your champions together and go. Find out more. And my final thought is, I am very grateful to your network, the Teleos's network, for your interest. And I only hope that today's podcast has served to increase your curiosity even more. We are more than willing at the IHI to take every phone call, every email. Just let us know. We're here to help you, but honestly, come join the party. It's a wild ride.
Kelly, what would you add?
Sure. At a very practical level, I will add that Margherita and I are working our butts off with our team to get the age-friendly care description for hospice out into the world. I think we're within a week or so of doing that, and that will allow people to seek age-friendly recognition for hospice care, which is very exciting. We are putting out a supplement that helps explain the distinctions of age-friendly care in hospice as opposed to home health. So great information coming out, hopefully, soon in July. There's a wealth of free resources at ihi.org, age-friendly. And I'll make sure you have that link, Chris. Our email is afhs@ihi.org, age-friendly health system at ihi.org. Margherita is completely right. We want to take your calls. We want to have these conversations. We are available. And we're available because of the generosity of the John A. Hartford Foundation, which I am so grateful for. So our door is open, so many resources available. And my answer to your question at a not concrete level of like that is, I want leaders of hospices to know you lead organizations that are needed and misunderstood. And they are needed as greatly as they are misunderstood. And you don't need to be ashamed of what you have. You never need to apologize for what hospice is. Hospice is phenomenal. Hospice is important. Hospice is how we care for each other. Hospice is how we acknowledge that death is real, and that it's not the enemy of medicine. So hospice is critically important in how we are a functioning, caring society. So please don't ever, ever, ever be embarrassed about that or feel like you need to hold back in some way. And if, as Marguerite has said, if what matters is your North Star, you're not going to go wrong. So this is a way of framing and holding the cohesiveness of the care plan together in a way that really works patient by patient. That's the individuation. Yes, you need to build reliable systems, but the what matters piece is how you individualize those reliable systems. So I'm excited by what's ahead. I'm excited.
Well said. Well, ladies, thank you for the work that you're doing. Again, I'm no one's ever asked me my superpower, but maybe my superpower is I have a hunch this is so important. And then I get in the podcast and go, oh my God, the hunch was right. And so that's exactly what I feel about this work that both you ladies are doing. Just thank you to both of you. You're doing very important work.
And
Appreciate
now you go, a guy. You know, two.
Yeah, now I know a guy. I know two gals.
Thanks for sharing your superpower with us. It's a privilege to be here. So thank you.
Take care.
Yeah, thank you. And to our listeners, we want to thank you. At the end of each episode, we always share a quote, a visual. The idea is to create a brain bookmark, a thought prodder about our podcast subject to further your learning and growth, and thereby hopefully your leadership. And we're going for like a brain tattoo. We want it to stick. Be sure to subscribe to our channel. We don't want you to miss an episode. And if you're interested, you can check out the book Anatomy of Leadership on Amazon. You know, it's easy for us to rail against the world. Let's be the change we wish to see in the world. So thanks for listening to TCNtalks, Anatomy of Leadership. And here's our brain bookmark to close today's show.
The patient is not someone we do things to. They are the center of care, by Margherita Labson. The 4 M's is a framework that helps us talk about what great hospice care really is, by Chris Comeaux.